This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, cardiologist at UAB St. Vincent's.
Well, welcome to MyHeart.net, and today we're exploring an important question for AFib patient. What happens when you're at high risk of a stroke but can't take a traditional blood thinner? So for us today, we have Dr. Charles Pollack, a cardiologist and researcher who's been following new therapies very, very closely. And actually, for the purpose of this discussion, Charles is a discussant, and consultant with Novartis, and has been very active in, with multiple sites for the recruitment of patients, with this trial. So, Charles, thank you very much for taking the time, and welcome to our podcast.
My pleasure, Alain. Thanks for having me.
Very good. So, I think if we discuss AFib, we know AFib is very prevalent. We look at the, possibly over 6 million people with AFib nowadays, and we predict by 2030 it will be more in the range of 12 million. And the main problem with AFib is because it can cause stroke. If you have AFib, the risk of stroke is 5 times higher. And if you happen to have had a stroke and you have AFib, your risk of another stroke is twice as high in the next 6 months following that stroke. So it's very difficult to, obviously, to balance the risk of a stroke and with the risk of, bleeding, particularly the way that we prevent stroke is by giving blood thinners. We've had a lot of experience with it, and I think these medications are pretty good. You can reduce stroke to 1% or less, but it's always a problem with the bleeding as a clinician and also with our patient. And some of these bleeding risks can go to as high as 2 to 15% per year. So, Charles, tell us, why are these situations so challenging in clinical practice?
Well, Alain, you brought up a very important point, which is that patients who are on a blood thinner are very attuned to the risk of bleeding. And they often see that in minor ways, brushing their teeth, they see blood in the sink. They may see a little blood in their stool. They bruise easily. They don't like it. And it reminds them that they have an anticoagulant or a blood thinner on board, but they don't necessarily feel the impact of stroke reduction. So it's very important for us clinicians to explain that to patients and to their caregivers, that the only way we have of trying to reduce the risk of stroke associated with AFib, which, as you mentioned, is 5 times more common than an age and comorbidity and sex-matched patient who doesn't have AFib. Not only is it 5 times greater, but the likelihood of death from that stroke with AFib, and maybe even more importantly to a lot of patients and caregivers, the likelihood of severe disability from that AFib associated stroke is high. Many patients will tell us that the only thing they fear worse than dying is being completely disabled by a stroke and having to depend on others for feeding and toileting and all of their activities of living. So we like recognizing those numbers, and those numbers have been known since the 1940s, but we haven't had really predictable and safe anticoagulants until about 15 years ago, when the first so-called DOAC was approved in a comparison study against warfarin. Since then, some other DOACs have been approved, and we tended to view those as sort of the ultimate in anticoagulation for stroke prevention in AFib. We didn't think we could get much better than the 1 to 2% major bleeding risk that you mentioned in your introduction, and the substantial reduction, at least as good as warfarin, if not better, in the risk of stroke. The problem is, as you mentioned, the incidence of AFib is greatly increasing. That's in large part due to the aging of the population globally. And with aging comes not only an increased risk of AFib, but also an increased risk of bleeding, whether you're taking a blood thinner or not. And that's attributable to fragility. It's attributable to loss of muscle mass. It's attributable to loss of renal function that is gradual in some patients, is more rapid in others. All of these things tend to increase their bleeding risk. And then when we add an anticoagulant, one of the currently approved anticoagulants, which are still warfarin, warfarin's still out there, or rivaroxaban, which is Xarelto, or apixaban, which is Eliquis. There's a little bit of use in the U.S. of Savasa, which is edoxaban. These drugs, again, safer than warfarin, but there is still this residual risk of bleeding. You add that to the risk of bleeding in one of these older comorbid patients, and sometimes physicians make the understandable decision that the risk-benefit balance has changed as the patient's gotten older and developed these comorbidities. And now all of a sudden it appears to them that the risk of causing a bleed, which can be substantial, uh, versus the risk of preventing a stroke, is they're more at equipoise now, and perhaps the bleeding risk is even higher. Even more frustrating for us as clinicians is sometimes patients will make that decision for us. They'll say, I'm not taking that stuff anymore. I'm tired of bruising. I'm tired of bleeding from my gums. My family says it looks like I've been beat up because I got bruises all over my arms, and I'm not going to take this stuff. So, as a combination of all of these issues, we now have more and more patients who should be, by clinical guidelines and by our clinicians' intuition, should be protected against stroke for their AFib with an anticoagulant. But the available anticoagulants that have been approved by the FDA don't have enough of a safety profile that we can say, we're confident that we can prevent stroke more likely than we are to cause a bleed.
Yeah. Well, thanks, Charles. It's so true. And if we look at our patients, we look at what increases their risk of stroke, like hypertension, diabetes, a previous stroke. It also, these are factors that increase their risk of bleeding. And we can measure that, with has bled. And when you look at, for example, a patient that has, we use these scores, and we can refer in the article, but we use the CHA2DS2-VASc score, for example, of 4. It will give you an annual risk of 4%, 4% risk of stroke per year. But if you you look at their has bled score of 4, that's double the annual risk of bleeding, almost reaching actually 9%. And if you calculate that for a period of 10 years, because we follow these patients, serially for year after year, after 10 years, the risk of bleeding is 60%. I mean, so this is really real, and this is what we have to deal with in clinical practice, every day with our patients. Well, obviously, we still, let's delve maybe a little bit more in these kind of coagulation factors, because we talk about medication like Coumadin or warfarin. We know that this medication for some patients is the only option. If you have a prosthetic heart valve, obviously you need to have warfarin or vitamin K antagonist. And Coumadin is more like the shotgun approach, right? And we kind of try to reduce the production of these little proteins or coagulation factor in our blood, particularly factor 2, 7, 9, and 10, as well as protein C and protein S. For some patients, at some point, that's all we had, for non-valvular AFib. But you mentioned the DOAC, or the direct anticoagulants, and mostly we're referring to the Pradaxa and the factor 2 inhibitor, as well as factor 10 inhibitor, particularly popular since, for 15 years now. It's been probably the best anticoagulation that we could dream of, particularly with rivaroxaban and apixaban. We have some very good, results in terms of stroke prevention, but, significant bleeding still, particularly with rivaroxaban, and we'll talk about that in a little bit. But now we're talking about factor 11. So maybe you could explain to us and to our patient, what's the role of factor 11? How does it compare to factor 10? Why could it become the ideal anticoagulant?
So this is a relatively recent discovery that we could potentially impact the risk of abnormal clotting, which is what results in stroke and AFib, without impacting at least nearly as much the ability to clot when we need to clot. So, for example, if you are injured, or if you're in surgery and you're bleeding, anticoagulants that follow the mechanism that apixaban and rivaroxaban and warfarin follow have a rather equal impact on hemostasis, which is good clotting, physiologic clotting, and thrombosis, which is the abnormal clotting that we don't like to see in a stroke vessel or in a coronary vessel causing a heart attack. So we used to think, and we thought for many years, certainly when I was in medical school, we thought that these processes were pretty much inseparable. And we just try to block what we can and then protect patients from whatever the downside is. But it turns out that inhibiting specifically this factor 11, we think, can prevent pathologic thrombosis without interfering with normal hemostasis, normal blood clotting. Now, why do we think that? Well, the main thing that started this whole line of thinking that got us to where we are today is that it was recognized that there are a fair number of people in the world. They're disproportionately represented among Ashkenazi Jews, but there are other genetically similar and homogeneous populations as well, are actually born without factor 11. Now, those people who are born with no or with very little factor 11, a number of decades ago, were termed hemophilia C, which is very unfortunate because hemophilia A and B, which is what lay people think of when they hear hemophilia, is people who spontaneously bleed, who can't participate in any strenuous activities, who often have to go into the emergency room to get factor transfused into their bodies and blood transfused into their bodies. It's really a horrible disease, standard hemophilia. There's some interesting gene therapy that's coming along now that may fix that, but we're not there yet. Calling congenital absence or deficiency of factor 11 hemophilia C is a misnomer, I think, because these patients do not spontaneously bleed. And what we found by looking at these populations in depth is that they do not have problems with nuisance bleeding or with spontaneous bleeding into their joints or hemorrhaging after a minor injury, the way hemophilia A and B patients do. And they have, if you follow them out over years, they have a lower risk of blood clots in their veins and in their arteries. Uh, and so what we've discovered from that is that it looks like if we can block factor 11 to sort of recreate or approximate that congenital state, it may be that we can reduce the risk of abnormal clotting without impacting the necessary clotting that we need in an injury or in an operation. So that was very exciting. The realization led to a further characterization of what we call the coagulation cascade, which is where a number of these factors, these small proteins that you mentioned, activate each other and continue along a chain until ultimately we have a clot. So when we thought that maybe this wasn't all one process, that there was two different processes that largely result in either normal clotting or abnormal clotting, people started looking at animal models. And in animal models, you can create animals that don't have factor 11. And in fact, those animals behave just like the humans do. They don't have untoward bleeding, and they don't have difficulty forming a clot when they need to. So that led to further development of a humanized protein to block either factor 11 or factor 11A. The A just means that it's activated factor 11. And now that's being assessed. It has been assessed in some small phase 2 studies. Now it's being assessed. This strategy of either 11 or 11A blockade is being assessed in multiple phase 3 studies, which could, I mentioned earlier when the DOACs came out, we thought, okay, this is it. This is great. We've got something better than warfarin now, finally. It may be that we even have something better than DOACs here coming to us in the clinic over the next couple of years. So it's a very exciting prospect. But again, it's the whole foundation of it is a very finite interruption of one part of normal blood clotting. Whereas the other drugs you've mentioned that are currently approved by the FDA, warfarin, apixaban, rivaroxaban, edoxaban, those drugs are much more generalized. They attack the clotting cascade either at multiple places, as you mentioned, that shotgun approach with warfarin, or they attack specifically the factor 10A step. Now, I know this is confusing for people who haven't studied this, 11, 11A, 10A, but the important part about 10A is that factor 10A, which is where rivaroxaban and apixaban work, is the part where the thrombosis pathway and the hemostasis pathway meet each other. So If you're hitting only factor 10A, then you, by definition, are going to impact the ability to normally clot or physiologically clot and the tendency to pathologically clot. What we think, and again, we've seen some early data that really supports this and is consistent with the natural history of patients who don't even have factor 11, is that if we can stop just factor 11, then we only impact the thrombosis side. It's referred to now as a hemostasis sparing anticoagulant, meaning that hemostasis, which is the normal clotting you want in an injury and surgery, may be preserved, may be spared while you're still preventing these clots that create problems like strokes and heart attacks.
Well, for my patients, I tell them, obviously, if you cut yourself, you need to be able to stop bleeding. And
Yeah,
factor 11 is actually kind of a bystander in that process,
exactly.
basically mostly there for kind of just kind of maybe the formation of a clot to be a little bit more solid. But obviously, if you have a abnormal clot in your body, like an AFib, you have clots in the left atrium, that's pathological, that's abnormal. And their factor 11, I think, is pretty important. And it can be actually a factor that is important in the propagation of that clot, that abnormal clot. So factor 11 could be really kind of a crucial. Well, obviously, as you mentioned, Charlie, there are several in development, several medication to block factor 11. There's some small molecules, and we'll talk about them maybe in a little bit. There's also some antisense, factors, and there is an antibody that you've been involved personally with Novartis, and it's called abelacimab.
Yes.
Can you tell us a little bit about this new antibody to block factor 11?
So the problem with factor 11 is that when the blood clotting process is initiated, it is immediately converted to factor 11A. What abelacimab does is it is an antibody to factor 11, to the original molecule. And we tend to think of antibodies often as like antibodies to viruses or antibodies to bacteria. What antibodies do is that they lock on to their target in a way that they don't separate. It's an enduring lock. And it turns out that abelacimab is an antibody that was built to target only factor 11, the non-activated factor 11. And the way it actually locks on to factor 11 uh, means that the ordinary things that activate factor 11 to 11A, which is again where the cascade starts, that can result in abnormal clotting, and those things are thrombin, factor 9, and factor 12. Again, for lay people in the audience, I apologize for all this factor talk, but just understand it's been well worked out, and what we've been able to show is that abelacimab, once it binds to factor 11 in the human body, blocks it from being activated by those normal processes. So that means you're going to have very little, if any, factor 11A present in the body, which means that pathway that leads to pathologic thrombosis is effectively blocked from the top, as opposed to where the 10A inhibitors like apixaban and rivaroxaban try to block it towards the bottom of that cascade. And at that point, it's also interfering with normal blood clotting.
Now, in phase 1, phase 2 studies, how effective is abelacimab in blocking the factor 11, Charles?
So we look at two things in phase 2 studies. Phase 2 studies are traditionally safety studies, right? And so when you're talking about safety of an anticoagulant, a blood thinner, doesn't matter which one you're talking about, the primary safety issue is bleeding. Does it cause untoward bleeding? Because we've always been trained to think that if you give a patient a blood thinner, they're more likely to bleed than if you don't give that patient a blood thinner. So in phase 2 studies, in the two main ones for abelacimab were in venous thromboembolism, DVT, blood clots in the legs after total knee replacement. And that's a fairly standard study for a blood thinner in development, because the risk of developing a blood clot in the leg after knee replacement and the timing of the development of that clot are very well characterized. So it gives us an opportunity to look at basically a known quantity to assess whether or not the drug is working. The other thing that we want to assess is in two ways. The actual impact on factor 11, which again, we've positioned as being so important in this process. So you can look at that in two ways. The probably the easier way, because it's not subjected to the whims of, hundreds and thousands of individual patients who all have a little bit different story in their lives and in their bloodstreams, is to look at the actual inhibition of factor 11. And what's been found with abelacimab, both in the post-knee replacement setting and in the AFib setting in phase 2, is that uh, abelacimab can achieve essentially 100% blockage of factor 11, meaning that it can't convert to 11A. And if it can't convert to 11A, then it can't kick off that pathologic thrombosis function. The other way we look at it, of course, is what it traditionally is considered efficacy, which phase 2 trials usually don't measure, or at least they don't have enough patients enroll them, enough statistical power, if you will, to measure efficacy. But the way it's great to say, look, in the test tube, I can show you that this patient's factor 11 was 99% inhibited, and it stayed that way for 30 days. But what really the patient wants to know, and what ultimately we want to know, is, well, does that keep me from getting a blood clot? So far with abelacimab, there's been pretty good correlation between the degree of factor 11 inhibition and the absence of blood clots. That was shown better in this model after the knee replacement, where I told you that the likelihood of clot is so predictable and the timing is known, than it is in the phase 2 study of atrial fibrillation, because we know that you mentioned a patient with a CHADS2 VAS score of 4 has a 4% risk, 1 in 25, of having a stroke this year. Uh, that's a higher stroke risk than I want. But the fact of the matter is, only 1 in 25 patients who have that score will have a stroke this year. And so you may have to follow them for many years to see whether or not the drug is actually effective at preventing stroke. Whereas with the blood clot in the leg after surgery, if you make it out to 6 months, you've got a good story. You know that you've had efficacy. So what we have on efficacy so far looks very promising. What we have on safety so far in terms of bleeding risk, and also the counterpart of that, which is this inhibition in the lab of factor 11, look very, very solid.
Sounds good, Charles. I mean, obviously, I think that the steps have been taken. They were studying in the venous thrombosis, and it looks very effective compared to enoxaparin after a knee surgery. So that really looks good. How about with AFib? Because I think that work is pretty important, because AFib is also a low pressure system. I mean, you think about the
Yes.
vein, obviously in the leg, and you think about the pulmonary vein, and you're in the back in the left atrium. That's usually a low pressure system. And you have a phase 2B study, which was very, very important, Azalea or TIMI
Yes.
71, compared to rivaroxaban. Can you tell us about that? I mean, this I think is pretty exciting.
I think it is too. It's certainly the best phase 2 results of any agent targeted either factor 11 or 11A in the AFib space so far. And basically, the patients enrolled in Azalea were at least 55 years old. They had AFib. They had an elevated CHADS VAS score, which means they had a known higher risk of stroke. And they were randomized to receive either rivaroxaban, so Xarelto, a drug that is used worldwide, is licensed around the world for prevention of stroke and AFib, or one of 2 doses of this new antibody anticoagulant, abelacimab, either 90 milligrams or 150 milligrams. Rivaroxaban, as many of our listeners will know because they're on it, uh, is taken once a day, every day. And in fact, if you miss a couple of doses, the efficacy starts to drop pretty quickly. That's important because sometimes when patients notice more bruising than usual, or more bleeding from their gums than usual, they'll deliberately skip a dose. And sure enough, that'll probably make the nuisance bleeding get better, but it also means that their protection from stroke is gone. So the really interesting thing about abelacimab is that, again, it's injected just under the skin, the same way insulin is injected, or Wegovy is injected. All of the drugs that people know about now. It's injected once a month. And what the Azalea data showed, before I get to the clinical results, what the Azalea data showed was that inhibition of factor 11, particularly with the 150 milligram dose of once a month again, of 99 to 100%, was still there a month later. So even if a patient's a week late in getting their second shot, they're probably still protected very well, as opposed to the concerns that can arise very quickly when you miss a once a day pill. So uh, we had this idea that we talked about a moment ago that inhibiting factor 11 could impact the likelihood of pathologic clotting, pathologic thrombosis, but it wouldn't interfere with hemostasis, meaning it wouldn't cause bleeding. Remember that term, hemostasis sparing anticoagulant? So it turns out that the risk of bleeding among patients taking abelacimab, both doses, but it's the 150 milligram dose that went forward because the effect is a little more consistent when you get out to the day 25, day 30. Both doses of abelacimab showed markedly less bleeding than the patients who were taking rivaroxaban. Rivaroxaban is a good drug. Most people consider it certainly to be better than warfarin in most ways, with the exception maybe of GI bleeding. But it's a good drug. And that being said, the Data Safety Monitoring Committee, the people who follow the study and can tell what patients are getting and what their outcomes are, told the sponsor of the study that they should stop the study prematurely. They should stop it early because the risk of bleeding with rivaroxaban was not going to be overcome, no matter how long they continued the study. Abelacimab was always going to be safer. So they stopped the study. What they noticed particularly, I just dropped a little hint there a moment ago, that one of the problems with rivaroxaban compared to warfarin is that it's increased GI bleeding. GI is gastrointestinal, so bleeding from the mouth, the stomach, or bleeding from the bottom, or anywhere in between. That's sort of the Achilles heel of the DOACs. Even apixaban, which was not was better than warfarin with GI bleeding. It's still the GI bleeding risk is still there. GI bleeding is the most common source of bleeding in patients taking DOACs. So in patients randomized by chance to abelacimab, the risk of GI bleeding was very near zero, which is that's a particularly cogent point of comparison because it has been a problem for the DOACs. Now that's the efficacy side. You had the safety side. You had that very strong and persistent inhibition of factor 11 actually did result in lower bleeding risk.
Yeah.
In fact, that committee, that data safety committee, recommended that patients who had been randomized to rivaroxaban be offered the opportunity to switch to abelacimab, despite the fact that we didn't know whether it prevented stroke or not. We just knew it was safer. So of those patients on rivaroxaban who were said, it's up to you, sir or ma'am, if you'd like, we will provide you this once monthly shot that we're not sure prevents stroke. It's not approved by the FDA, but we know it's safer than rivaroxaban, or you can continue what you're taking now, which is a drug that's been approved by the FDA, the European authority, all over the world. 87% of patients who were asked if they wanted to switch decided to switch. So that gives you an idea of two things. Number one, how much the nuisance bleeding is a problem for patients. And number two, how much they don't like taking a pill every day.
In clinical practice, Charles, it's about 25% increased risk of GI bleed, with DOAC, particularly rivaroxaban. What was interesting was the little sub-studies, particularly patients, that are needing to undergo procedure, which is kind of a pain. Every day you have to kind of clear someone to get a procedure, whether it's a surgery, whether it's a dental extraction, whether it's a hip surgery or a cardiac cath. You have to hold the DOACs. You have to hold this medication. So I think it would be interesting to see how was that handled when you have a medication that is in your system for a whole month and beyond. How did the procedures went? And was there any complication, increased bleeding?
Yeah. So a couple of things of interest here, Alain, and thanks for bringing this up. The paper on this data was just published earlier this year. When we talk to clinicians about joining a study where they're giving patients a month-long anticoagulant, their first concern is always, what happens if my patient falls? Or what happens if my patient starts to have a GI bleed? How do I turn this thing off if it's there for a month? Okay. And the other issue that frequently comes up is You know, how do I know this is safe? When when I have to do something to the patient. You talked about this need to, if a patient breaks a hip or needs to go to the cath lab, often that can be delayed a couple of days while rivaroxaban or apixaban is stopped. The problem is when it's emergent and you can't stop it. So if that happens in a patient on abelacimab, all of a sudden you're dealing with a drug that, if it was dosed a week ago, you expect to still be active for at least 23 days. So that makes the surgeons very nervous. Surgeons are always very nervous about bleeding, and they don't mind sharing that opinion. So we knew that this was going to happen. I mean, in Azalea, again, patients had AFib. They had an increased risk of stroke. They were at least 55 years old. Many of them were much older than that. We knew that some of these patients are going to have a need for an urgent procedure or surgery that ordinarily would be concerning for a patient taking an anticoagulant, much less a long-acting anticoagulant. So what was done in the protocol was that types of procedures were ranked, and there was a document from the American College of Cardiology that helped with this, ranked in terms of the risk of bleeding on the procedure, whether the patient's anticoagulated or not. And some are at low, some are at moderate risk, some are high risk, some are very high risk. Low risk, for example, would be a cataract extraction. It doesn't matter whether the patient's anticoagulated or not. There's basically no bleeding from that. Whereas high risk would be spinal surgery, or a patient who comes in with an aneurysm in the aorta that's leaking. These are patients that are going to bleed again, even if they're not on an anticoagulant. But the issue would be much more concerning if they were on one of these blood thinners. So for each one of those categories, there was advice given to the investigators. Now, it's important to note that in Azalea, the investigators knew whether the patient was abelacimab or rivaroxaban. Okay, it wasn't double blinded. Whether or not the patient was on 90 of abelacimab or 150 of abelacimab was not known to the treating physician, but they knew the patient was on abelacimab, this month-long anticoagulant, or rivaroxaban. So for low-risk patients, no specific advice was given. For moderate and high-risk patients, it was advised that a non-specific antifibrinolytic, such as TXA, be given to these patients empirically, just to help with hemostasis. If patients had a higher risk of bleed, if they had one of those very high risk procedures, or if during the procedure they started bleeding and they were known to be on abelacimab, then the advice was to give them recombinant factor 7. Okay, now TXA is available basically everywhere. It's inexpensive. Recombinant factor 7 is not available everywhere, and it's quite expensive. So we knew this could be a problem. The advice for rivaroxaban was, doctor, follow the label. There's advice in the label based on the time of last dose of the patient's renal function of how long rivaroxaban should be held, if it's possible, in an elective procedure, to ensure good hemostasis. So we then followed these patients out, and it turns out that about 34% of patients in both arms, the abelacimab arm, the two doses pooled together, and the rivaroxaban arm, over the course of follow-up, which was about 2.1 years, had a need for a procedure while they were on anticoagulants. And the patients who were on abelacimab had no higher bleeding risk than the patients who were on rivaroxaban, where the drug could be interrupted if necessary, or a specific reversal agent could be given. So it was very reassuring. This was true whether the patient had a procedure 1 day after that 30-day dose or 34 days after that 30-day dose. It didn't seem to matter. And we know from other studies that near complete inhibition of factor 11 is still persistent out there. So this was very reassuring. And most importantly, it confirms this idea that we know from people who naturally don't have factor 11, don't have worrisome bleeding except in very unusual circumstances. Interestingly, not many patients got TXA, which again is widely available and cheap. Most physicians didn't think they needed it. No patients got recombinant factor 7. So the drug behaved, rivaroxaban behaved too, but we know what rivaroxaban does, and rivaroxaban's gone in a few hours after you take it. This drug that hangs around for 30 days behaved very much the same way. And there were certain subsets where it actually was superior to rivaroxaban, but once you get into secondary data cuts, it's less precise.
that's very
yeah,
informative.
it's very reassuring
yeah,
for
yeah,
our
very
surgical
reassuring.
colleagues. Yeah.
I mean, I can see, for example, my 80-year-old, patient who wants to be on something safer because she's frail and she falls a lot. And sure enough, you give her the dose, and a few days or a few weeks later, she falls and breaks a hip and has to have, hip surgery. Is, comforting to know that she can have that surgery without, much problem at all. I mean, very,
Yes.
very good.
So the data we have so far is very reassuring. It is admittedly mostly for those low bleeding risk procedures and for for elective cases where there can be a delay if needed. That delay, of course, is more important to the patients being treated with
Right.
rivaroxaban.
There
We
was a
still,
bit of, I'm sorry, there was a bit of data also on patients that are on antiplatelets, but
yes,
I guess there was not that many patients,
no, not that
too
many, but
small numbers to say.
yeah, we
Yeah.
know that both coronary artery disease and peripheral arterial disease coexist with AFib a lot. And so there are patients out there who, in addition to whatever blood thinner they're taking, are also taking aspirin or Plavix, clopidogrel, or ticagrelor, Brilinta. Um, there weren't many in this
Right.
analysis. There will be more in the phase 3 study that's going on now.
Right.
But it turns out that just as we have known, and just as guidelines recommend, and the package insert recommends for rivaroxaban, if a patient is given antiplatelet therapy on top of rivaroxaban, you can expect the bleeding risk to go up. And in Azalea, it did.
Yeah.
The interesting thing is the patients who got abelacimab, either dose, didn't matter which one, did not get an increase in bleeding when they were added or when they were put on
Yeah.
an antiplatelet. So again, small sample, but
Mhm.
all of the secondary analyses have been done. The two that we've talked about here, antiplatelets and surgery, but also advanced age, renal function, prior bleeding history. Every secondary analysis has been done so far has been consistent with the primary results of the study, which were that abelacimab is so much safer than rivaroxaban that the comparison should be stopped.
Yeah. Very, very good. So obviously, all of this is very encouraging, Charlie. But there is this elephant in the room, and this asundexian, which
Yes,
was an oral anticoagulant, a factor 11 given once a day. I mean, they enrolled almost 15,000 patients, and the study was stopped prematurely because of lack of effect. Can you
right.
tell us a little bit about that? And is that kind of like creating a little bit of cloud, over the sky of factor 11, or do you think it should be taken in stride? And maybe there was some problem with the study project of
Well,
asundexian.
it certainly has to be taken into the context of the whole issue. But a couple of things. At one point, Elaine, as you know, there were 3 AFib studies going on with factor 11 or 11A inhibitors. Lilac, which is the abelacimab study, is still ongoing. Librexia AF, which
Yep.
is a study of milvexian, which is a factor 11A oral inhibitor given twice daily. And then there was Oceanic AF, in which the drug you're mentioning, asundexian, was given once daily. Okay. Both of those small molecule studies, the Librexia with, with
Milvexian.
milvexian and the Oceanic with asundexian, patients were randomized to receive either apixaban, which we know is a very good stroke suppressing agent in AFib and is also probably, well, arguably the safest of the DOACs, or that factor 11A inhibitor. Okay. So that's one difference between the Lilac study and the Oceanic and Librexia studies. You got 11 being blocked, which means 11A had never even formed. And then you've got these pills that chase the 11A that has been formed and try to bind it up. Okay. It's not like an antibody, they competitively block it. So already there, of the 3 studies, there's a difference between 1 and 2. There's another difference, this time a different 2 versus 1. Both abelacimab and milvexian had studies like the one we talked about, which is the total knee replacement study, which gives us the idea to see what dose should optimally be used to prevent clotting. Okay. Asundexian did not have one of those studies. And the concern is that asundexian may be a very good factor 11A inhibitor, but it wasn't given at the right dose because they didn't have that patient guidance the clinical trial guidance to support the dose.
Yeah.
So the other issue, again, 2 versus 1, is that both the factor 11 inhibition activity of abelacimab and the factor 11A inhibition of activity with milvexian are well characterized using standard assays. The company that has asundexian found that those standard assays, to their way of thinking, didn't measure accurately the inhibitory activity on factor 11A of asundexian. So they used a different assay, and using that different assay, they said, well, we're above 90% inhibition of factor 11A, but that hasn't been verified by any other standard study. So there may be a number of reasons with the study. I think the most likely of which is that it was underdosed. I don't know that it'll ever be studied again at a higher dose. But as you pointed out, the something was wrong. The dose was insufficiently measured, or something led to a finding of inferiority for efficacy, so that patients, even before the study was complete, it was seen by one of these independent data monitoring committees that patients on apixaban were having better outcomes in terms of stroke reduction than patients who were receiving asundexian. So they said, stop it. This is not safe. Ethically, we can't continue this study. These patients should all be given the opportunity to switch to apixaban.
Yeah.
Now, for what it's worth, the factor 11 hypothesis or 11A hypothesis, it turns out that those patients who were given asundexian actually did have they had a lower bleeding risk than apixaban patients.
Right.
And apixaban, again, is, we think, the best DOAC for bleeding reduction.
Yeah.
So
Yeah.
there was still a silver lining in that cloud. But you're right. When that came out, there was a lot of doom and gloom of patients saying, see, these 11s and 11As aren't going to work. This is a class effect. Well, my first response to that was 11 inhibition and 11A inhibition are not in the same class. They have very different mechanisms, because if you never allow factor 11A to be generated, then you're likely to have a more profound effect on downstream clotting than if you're chasing the factor 11 that's already been formed.
Yeah.
And secondly, I mentioned that both Oceanic and Librexia measured the activity of their 11A inhibitors, their oral 11A inhibitors, against apixaban. Abelacimab in its AFib study is targeting that population that you and I started this conversation talking about, which are patients who have AFib, who have a high stroke risk, also have a high bleeding risk, and therefore have been judged not suitable to take one of the conventional anticoagulants, or the patients refuse to take them usually because of bleeding. So in that study, we're actually comparing abelacimab to placebo. So the structure of this factor 11 inhibitor study versus the 2 factor 11A inhibitor studies was quite different. And so for all of those reasons I just enumerated, so the whole group of drugs is in jeopardy until we get more data.
Yeah. Well, Charlie, let's obviously you've talked a little bit about Lilac or TIMI-76. Maybe we could finish with this. We're about to engage a new site actually in Birmingham. I'm quite excited with Dr. Fadi Hogg, at UAB Veterans VA Hospital.
Yes.
We've been also part of that trial as well. We've enrolled a small number of patients. We have another one that we're about to enroll, coming up in the next week or so.
Oh, that's great.
It's the patients with no option. Can you just kind of describe maybe what are the inclusion criteria and what do we need to do to get on board with this very exciting study?
It is very exciting. It's also, as you sort of indirectly alluded to, it's a challenging study for a number of reasons. But just to go with the standard inclusion criteria, patients have to be at least 65. Remember, in Azalea, they could be enrolled if they were 55. They have to be at least 65. They have to have documented AFib. They don't have to be an AFib when they're enrolled in the study, but it does have to be documented. They have to have an elevated CHADS-2 VAS score. They have to be at least 3 if they're 65 or older, at least 4, 75 or older, at least 4 if they're 65 or older. They have to not be taking any anticoagulant, any blood thinner, for at least 60 days. Okay. And there's no intention of them going back on it. They've been judged either by themselves or by the treating clinician that they're not suitable for one of the conventional anticoagulants. And so they're left unprotected for stroke risk. They also can't be, one of the things that we do for patients like this, in many places, particularly urban areas, university settings, we have these devices that can potentially close off the area of the heart where the clot is most likely to form. If the patient has that or is going to get that, then we can't put them in the study because that would interfere with what we would hope to find as abelacimab's benefit. And the only other really exclusion criteria is that they can't be on dialysis. Now, they may end up on dialysis. We're hoping to follow some of these patients for as long as a couple of years. Some of these patients probably will end up on dialysis, but if they're on it or expected to go on it when they start, then they can't come in. So what we're doing is we're taking patients who have this high stroke risk. You mentioned something very important earlier, which is that the risk factors for stroke with AFib and the risk factors for bleeding with anticoagulation often overlap. They count double against you. So we're looking at a population that's been deliberately enriched to be high stroke risk or high bleeding risk. Because in addition to the standard inclusion criteria, they also have to have had a history of a major bleed before, or they have to be taking antiplatelet therapy, like we talked about, or they have to determined to be very frail or at high fall risk. So there's something that really enhances the likelihood of bleeding in these patients. So half the patients who meet all these criteria, who aren't going to get a Watchman or whatever device is available, are going to be placed on 150 milligrams of abelacimab, okay, once monthly. The other half are going to be placed on nothing. They will get a placebo injection once a month. But this is a placebo-controlled trial, and I think that's one of the reasons this study is challenging for us to enroll in, is because when patients and their family members see the word placebo, they start envisioning guinea pigs, and they don't like the fact that they're being, quote, experimented upon, end quote. So what we point out to them is that, sir or ma'am, if you are sitting here in my office eligible for LILAC, you're already on placebo. We're not going to change a thing that you're doing, except that once a month you're going to get a shot of salt water or sugar water, and otherwise you're going to get the same care you get now. So the patients who get abelacimab get the same care they get now, plus once a month they get this novel antibody blood thinner. We're going to follow these patients out. This is what's called an event-driven trial. So we don't know for sure how long it'll take us to get results, because the results that matter for showing efficacy of abelacimab versus placebo have to accrue. We have to watch them happen. We have to see how many patients who get abelacimab bleed versus those who don't get abelacimab, because as we talked about before, patients who are 65, 75, 80 years old and have some of these risk factors in their bleeding side, forget the stroke side, some of them are going to bleed anyway, no matter what they're on. And of course, as we mentioned, some of those can be on aspirin, or they may have clopidogrel, those can cause bleeding. And then the other thing we're going to look for is the incidence between the two groups of stroke. So we'll see if it's protective, and we'll make sure that there's no harm done from the bleeding. And this is a tough bill here. We're trying to be better than placebo. So it's in fairness to the Librexia AF people who are doing the milvexian versus apixaban study, they got a tough bill too, because trying to come up on top of apixaban is a challenge. But these two studies together take very different approaches to mechanism, to delivery of drug, but they both focus on that aspect of the clotting system that hopefully interferes much more so with pathologic clotting than it does with physiological needed clotting. So, in an ideal world, I think both studies would be positive. And we'd have more ways to treat these patients who right now are left unprotected because the risk of bleeding on a conventional anticoagulant is just too high. So it's a very exciting time in AFib management. These drugs are being studied in other indications as well, where there's clot involved, and maybe another time we can talk about that. But for AFib, this has the potential to be really paradigm changing. And hopefully provide these high-risk patients for stroke, also high risk of bleeding, with a way to reduce the stroke risk without making the bleeding risk any higher.
I think it's pretty exciting, particularly in these patients that have no option maybe there is something out there, in the future.
Yep.
Well, Dr. Charles Pollack, I want to thank you very much for, all the time you spend here really explaining well the coagulation factor, factor 11, and try to sort out a little bit where we're headed, in our armamentarium, for patients that have AFib, that are at risk of stroke, but also such an increased risk of bleeding. Maybe this is going to be a paradigm shift, in the way we treat those patients with AFib. I mean, factor 11.
Yeah, and one of the reasons it's so exciting, Alain, is that we thought that the DOACs were going to be the be-all and end-all of anticoagulation therapy. We didn't see that there was something else coming that might be even better. We don't know yet, but at least it might be better. And I want to thank you for inviting me. I also want to mention, I know a lot of your listeners are in the Birmingham area. I was born and grew up in Selma. So I have a great affinity for the people who you're taking care of. And I congratulate you on your excellent clinical work for years, and also for your successful participation in the study. I can't wait to get the Birmingham VA on board as well.
Sounds great. Exciting. Thank you, Charles. Have a great week. And factor 11 may be the future of anticoagulation in patients in AFib. Thank you,
Sure,
Charles.
maybe. Thank you.
Have a good day.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.